Cynthia, Cynthia, are you okay if we start?
Absolutely, thank you.
Yeah, thank you. Thank you. Welcome everybody to Transplant Rounds. And today we have we're very honored to have a guest speaker today. I think probably most of you know Dr. Maureen Meade. So Maureen is a critical care physician in Hamilton, Ontario. She's a professor at McMaster University and a senior clinician scientist. Among her various research and mentorship honors, Dr. Meade is current recipient of the 2020 CINERGY Distinguished Lecturer Award in Critical Care Sciences. So recently, Maureen has been working along with several other investigators, including Marcus Felsner, who unfortunately had to be in the OR, well, fortunately had to be in the OR this morning doing a transplant, on a very exciting study involving pre-treatment of donors prior to organ recovery and donation. And I won't give away any details of the trial, but where it's very exciting to have Maureen here to talk about it today. So over to you, Maureen.
Okay, thank you, Atul, and thanks everyone for attending this morning. It's a real privilege and opportunity for me to present to you the CINERGY pilot trial. And while Atul introduced myself, there's really three leads at the present time for this study. Frederick Daragon, listed here, is another intensive care physician hailing from Quebec, and he's really the principal investigator on the study. He designed the study and is doing the bulk of the work of navigating all the hurdles to making this a reality. And Marcus Seltzner joined us in this work sometime last fall as a co-principal investigator, because as you'll see, this study requires intense collaboration between transplant and donation communities. And his input has been invaluable to us around all sorts of transplant issues that are just foreign to us. So, oh dear, I can't seem to advance. There we go. Just as a matter of disclosures, I do receive personal funding as a hospital donation physician from the Trillium Gift of Life Network, and research funding for this particular work from Canadian Institutes of Health Research, Canadian Blood Services, and my home institution. And as a bit of background, I just wanted to show a few slides about the Canada Donate Research Program. So Frederick Daragon and I launched this program just over 5 years ago to begin developing Canadian capacity for clinical trials in deceased donor care. And this meant training up specialized research teams at the donation sites, at the organ donation organizations across Canada. And now at this point, we're really working hard to engage transplant sites. Over this period of time, we've addressed, largely through research, a lot of very unique legal, ethical, and practical challenges that arise in research on deceased donor care. And we've also been very fortunate to engage patient partners in this research. And this slide, which is far too busy for you to really appreciate, sort of outlines our research program and what we've done to date. And you can see to the far left, there's been a lot of work on the research consent process, systematic reviews, working with ethics panels, and some qualitative research now with transplant recipients, soon to be with transplant waitlisted patients, around the ideal models of research consent to work with them. Then there's been, in the next column, some research on donor care in the ICU, some cohort studies. I'll speak to one of those in a few moments. A lot of work on knowledge translation tools that will help us disseminate findings, but also help us to implement the research. And then also some work which is as yet incomplete, but we're developing a generic outcome measure which hopefully in the future will allow us to integrate the effects of a donor intervention on recipients of all organ types to help improve the statistical power of our analyses, for instance. And this is work that's actually been led by someone in Toronto, Fareed Fouratan, who works with Heather Ross. And then in the last column refers to the current RCT groundwork biomarker study underway in Quebec, and this pilot study leading to a full-scale randomized clinical trial. And the flagship study from the Canada Donate Research Program is this observational cohort study that we wrapped up a couple of years ago. This was actually Frederick's thesis for his graduate degree. You can see Frederick shown here. And it was a 12-month prospective study conducted in 32 adult ICUs in the 4 provinces across Canada that really generate more than 90% of transplants. And we enrolled every single one of 622 consented organ donors, like consented to donation, at these centers in this period of time. And we didn't miss a patient because of our close collaboration with the organ donation organization, which it will be crucial in moving forward with our randomized trial. And we collected all sorts of data related to donor treatments, investigations, and outcomes so that we could learn what's going on in the centers that will be participating in future randomized trials. And we collected data from the hospitals and some of it directly from the organ donation organizations. And there's all sorts of outcome data that has helped us generate descriptive analyses and some research innovations for the work ahead. And so that leads me to the CINERGY pilot trial, which is the focus of today's presentation. And as I present it to you, what I'd like you to think of is the relevance, not only with respect to this specific donor intervention that we have planned, but if you could also think of the relevance of this work as a pathway for research in deceased donor care, even future research in ex vivo interventions, any research where the intervention is applied before the organ is transplanted, because this is a pathway that could be utilized for your group, for other groups across Canada doing donor research or ex vivo research. And then at the end, I think we'll have easily 15 minutes or more for discussion around any medical concerns that you might have, logistical concerns, which we'd really like to hear about, and ethical concerns too. I see that Jed is in the participant list. So the research question that we aim to address is, does the administration of tacrolimus versus placebo to neurologically deceased kidney donors reduce kidney delayed graft function, reduce delays in function for all of the other organ transplants, because these may be multi-organ kidney donors, reduce graft loss at 1 year, and without increasing acute postoperative kidney injury? You folks know far more than I do about tacrolimus, but one thing that is crucial to know is that the immune and the anti-ischemic effects of this drug align so well with the pathways of ischemia reperfusion injury. And that's why there's been a lot of research now, a lot of interest in calcineurin inhibitors to prevent ischemia reperfusion injury, not only by our group, but other clinical researchers and definitely preclinical researchers. So we're just finishing up a systematic review of studies in animals, so animal models of organ donation and allotransplantation. And there were 18 such animal model studies. And 8 of them were conducted in kidney transplantation, some in liver, small bowel, and lung. So mostly in kidney, and moreover, those kidney studies were most extensive, investigating a variety of different outcome measures and just generating more data. All of the studies included either cyclosporin A or tacrolimus as the experimental intervention. And what we found is that across these studies, tacrolimus consistently improved recipient inflammatory cytokines, histologic findings of graft necrosis, and early and even delayed graft function. So in one study of kidney transplantation, there was a measure of graft function at 3 to 6 months post-transplantation. And so the results were consistently promising. So emerging data really suggests that we should be assessing this in the clinical realm. But of course, in the clinical realm, we also have to think of potential adverse effects. And for the kidney recipients, there's at least a theoretical risk of acute renal graft injury for sure. Acute ATN from afferent renal arteriolopathy, which is you folks know so much about, and also potentially acute hyperkalemia in that first night post-transplantation from Wnt kinase upregulation. So these are certainly theoretical, possibly real risks faced by the kidney recipients in the CINERGY study. But then there's also the potential for risks to other transplant recipients of these multi-organ donors, and the most worrisome being acute kidney injury. But as you might imagine, we're using a low dose, as you'll see, and the carriage of drug from donors to recipients via organ donation is very low. We've done a lot of mathematical modeling and calculations around this. But it still remains a relevant issue given the high risk of acute kidney injury for all transplant recipients. So what we've designed is a multi-center, randomized, placebo-controlled pilot trial. We now have Health Canada approval for the most current version of the study or of the protocol, and provincial research ethics board approvals for Quebec and Ontario, but we haven't rolled that out to individual sites as of yet. The first participants in the study, of course, are the donors, and there will be 90 organ donors in this pilot study. And the inclusion criteria are shown here. They have to be at least 18 years of age, have a neurologic determination of death, and formal consent for organ donation from the substitute decision makers. Before they're enrolled, organ allocation must be complete, and there must be at least one kidney allocated for transplantation. We will exclude these eligible donors if a transplant physician feels that for this particular patient, potential exposure of the organ to tacrolimus would not be advisable if they perceive a safety concern. Or if a recipient who's being offered the organ is reticent to receive a CINERGY study organ, then that eligible donor will not be randomized in the study. If one or more of the organs are allocated to a transplant center that's not participating, so most likely that will be a center outside of Ontario, Quebec, then we will not randomize the donor. And if one or more organs have been allocated to a pediatric patient. Obviously, the transplant recipients will reap the benefits of this intervention if it is beneficial, or bear the consequences. And so there will be roughly 300 transplant recipients for these donors, and we hope to enroll as many of these as possible in the into the study. So there are 7 donation intensive care units participating, just 4 from Ontario and 3 in Quebec. And so far, 26 of the 27 transplant programs have signed on in principle. But of course, we're making rounds now like this to every transplant program to ensure that everyone knows about it and has no concerns and will, agree for their program to participate. But in principle, 26, I think now it might be 27 of the transplant programs have signed on. And these are the study interventions. The experimental intervention is a low dose of tacrolimus, 0.02 milligrams per kilogram, intravenous infusion over 4 hours. And this starts 8 to 4 hours prior to organ recovery. And the control intervention is a placebo. So at the donation sites, we'll have no awareness of the allocation to experimental or control group. And so we will not be imparting that information to the transplant sites. And there are a number of outcomes of interest, particularly in the pilot study. We're very focused on the feasibility of enrolling donors in this research and enrolling recipients in this research. And so we're going to learn a lot, and we don't know which way it's going to go here with respect to feasibility. With respect to clinical outcomes, those here in the pilot study directly mirror what we'll be doing in the full-scale trial, and the primary clinical outcome is delayed renal graft function. But we'll also be assessing for a delay in graft function for other transplant types. And then we'll be looking at recipient and graft survival at 12 months out. And this is sort of a study within the pilot study, because we'll be collecting this data from hospital and transplant clinic records from CINERGY, and we are just finalizing the methods for obtaining that data from CINERGY with them right now. And for some recipients, if there's any difficulty with the former two mechanisms of data collection, we'll be making telephone calls to the recipients. So the purpose of this study is to really help us to understand what will be the most efficient way and complete way of accessing data for the full-scale trial. And then, as I've mentioned, the primary safety outcome in the pilot study will be acute kidney injury across all organ types, and we'll measure that as KDIGO stage 2 acute kidney injury. So one of the biggest challenges that we foresee for the CINERGY study, and which is why we're embarking on a pilot study, is the research consent for transplant recipients. So we've judged this to be infeasible to obtain in the pre-transplant clinic for most transplant programs. Some of them are actually going to do this, but as you can imagine, this would require education and training of research staff and transplant staff at all transplant programs across the 2 provinces, and then having discussions with every waitlisted patient. And clearly that is a lot of information to impart to a lot of people, very short transplant clinic visits. And so many of those patients waitlisted will never even be considered for the study, which is only being undertaken in 3 intensive care units in Ontario. So it's just not a feasible approach to the research consent. And so we've considered also getting the consent at the time of organ allocation. But again, we've judged this to be infeasible and also posing a risk of coercion, which research ethics boards agree with us about. Because at the time of organ allocation, some recipients are clearly incapable, whether they're encephalopathic or they're just so incredibly euphoric about this offer of an organ for transplantation. On the other hand, some of them, and we've learned this through some qualitative research, have these feelings of guilt, indebtedness to the donors, to the health system. So even if they're worried about participating in research, they might feel they have no choice. And so that's not a good place to be either. And then, as with the pre-transplant clinics, there's so much information sharing right at the time of organ allocation that we felt that is not the best time for the research consent. And so the approach that we've come up with is a staged approach to consenting recipient. Stage 1 is a clinical consent so this is consent merely to receive an organ from a donor that's participating in the CINERGY study. And then stage 2 is the research consent for the use of recipient data in the CINERGY study. And so this next slide takes you through this in a little more detail. So the green boxes at the top refer to the donor consent. So we'll just focus on the bottom. But at the time of organ allocation, we do the clinical consent. And usually this will be at the time of a telephone call from a transplant program coordinator, or possibly in some programs, it will be the physician making this call, offering an organ to somebody who's waitlisted. And at that time, just as the person making the call would speak to donor Hep C status, whether or not this is an extended criteria donor, a couple of other features about the donor, they would mention the CINERGY study. And this will be highly scripted, so people will know exactly what to say. The scripts will be reviewed by our research ethics boards in advance to make sure that it's all very clear and not coercive. And we anticipate that this will be a quick discussion, but it needn't be. And so some patients will accept right then and there during the phone call to receive an organ from a CINERGY study donor. And this information is clearly documented at the Trillium Provincial Resource Center by Trillium staff, and the clear documentation is sent on to the study group so that it's all very tight and there's no mistakes made about the clinical consent. And then the patient comes into hospital, and in most situations, as I understand it, they're in the hospital within a matter of hours. That won't always be the case, of course, particularly for some heart recipients that might come from far and wide. And so then there's another discussion and they'll receive an information sheet. They might discuss again with the transplant coordinator or transplant physician about the study. And even if they agreed up front, if they change their mind, as long as they change their mind before that infusion starts in the organ donor, then the donor won't be randomized in the study. So there's lots of opportunity. We think there's ample time and a lot of organization to undertake these discussions for the clinical consent before the recipient or the donor receives this infusion. And then after organ transplantation, there will be a discussion about the research consent. And so this will be conducted by our own critical care research coordinators in all of the transplant programs. Within the Canadian Critical Care Trials Group, we have this incredible network, and they will approach the transplant recipients. I imagine this will be in collaboration with the transplant program coordinators who will want to know about it for sure, might want to participate in the discussion. And this is where they'll sit down and do a formal research consent, going through the consent form, the risks, the benefits, and everything else. And this is a consent for the use of their data for measurement of study outcomes. And I might add that it's our network of research coordinators who will be recording all of this information, all of the data after they do obtain the consent. And there's no new data generated by the CINERGY study. It's just data that you are recording in your clinical practices. And if there's any reason that we cannot undertake the research consent face-to-face in the hospital, then post-discharge from hospital, we have authorization from the Research Ethics Board for a deferred consent, which will occur over telephone conversation. So I'm hoping that you'll have some comments to make about this, mostly the clinical consent operations at the end of this presentation, which is coming soon. So I did want to tell you a little bit about how we're informing the transplant community about this research. So the donation community, and it's more than just a few of us, it's people across the country, have been working on this program for a few years, as I've mentioned. And very early on, we've engaged the support of the Canadian Critical Care Trials Group Canadian Blood Services and the Canadian Donation Transplant Research Program. And organ donation organizations have worked with us on that flagship observational study, which really helped us get every single organ donor into the study, and will work with us a lot on identifying donors for this study and obtaining some of the data. And then last fall, when we were submitting to CHR Project Grant Stream for funding, we started engaging the transplant community more intensely. And so there are some transplant researchers on the grant, and this is when Marcus joined our group as really the lead from the transplant side. And we've just about finished our presentations with, we have finished our presentation to the Trillium Organ Group leads, and now we're presenting to all of the Trillium Organ groups. So I think we just have the lung group left. And we may revisit with some of those groups if needed. And now what we're putting a lot of time into is meeting with individual transplant programs, as we're doing here today. So even though a number of programs signed on in principle, we really need to make sure that everybody is aware of the study, that people are comfortable with the study, because I think that within each group, they'd like to see that everybody is on board before they officially sign on. And then we'll also be, there'll be a lot of education for the Trillium donation coordinators and transplant coordinators, and the coordinators within individual transplant programs as well. So these are these next 3 steps we'll be undertaking over the next few months to launch the study, hopefully in August or September. During some of our prior presentations, some people have asked questions about the implications for other research underway. So some of it is future research. I mentioned this before, like we really believe that this will be a great platform for other donor management and ex vivo studies, also transplant studies potentially. And this involves not only clinical research, but tissue research. So issues related to the recipient consent, for instance, and stuff that we've learned from patient engagement in this research will translate to other areas of research, which, you know, we just want to share as much as possible. With respect to concurrent research, so other research that's underway, in particular research programs, the question arose about, you know, can we have patients in more than one study at a time or more than one randomized trial? And we would have to take this on a case-by-case basis and have, you know, careful, thoughtful discussion with the PIs of the corresponding studies. Certainly in the critical care world, we co-enroll in studies all the time. And so we would be very open to co-enrollment wherever that's suitable. And in this program, we'll be developing standard operating procedures for how we address co-enrollment or just exclusion of 2 studies going on at the same time in some centers, and how we'll address the allocation of particular patients in particular programs to different research studies. So that will require more discussion along the way, I'm sure. So I thought that I would wrap up the presentation here, and to leave lots of time for answering your questions and further discussion. So thanks very much for your attention.
Thank you, Maureen. I think, thank you for highlighting all the challenges, especially in doing this type of study, and congratulations to you and your team for taking on this challenge. So I'm sure there's going to be lots of questions. Maybe while we're waiting, I can start. You know, there have been several very nice donor intervention studies that have been published in the past out of the US and other places. And I'm thinking, for example, that the donor cooling study that looked at the donor cooling and was a randomized control trial and looked at effect on outcome of recipients. And I'm wondering, have you looked at the consent processes in those studies and see if there's anything we can learn from that?
We have, and we've had a lot of help from Klaus Niemann and Darren Malinowski along the way, or consultations, but as it happens, it's easier in the States because neurologically deceased donors don't have the same rights as they do in Canada. And so discussions with them hasn't been, well, they did, they had their own challenges, to be sure. They're just different challenges, I would think, in Canada, but it's been very helpful to learn about how they just engage different programs along the way, and all the work that went into that, for sure.
Interesting. Okay, so we have Jeremy, Anna, and then Dipali.
Hi, thanks, Maureen. That's really excellent and really interesting. Quick, just practical question. So you're consenting the recipient, presumably a renal. Are you consenting all the recipients of all the organs, and then
Yes.
presumably when you're consenting them, you're telling them that the organs is theirs, whether or not they accept to be in the trial, right? I mean, you can't. I presume that the organ allocation occurs, and then the decision about whether to administer the drug to the donor then occurs. But my question is, then, practically speaking, you would require the consent from all the recipients to be unanimous.
Mm-hmm.
And are you collecting consent from all non-renal donors too?
Yes.
So if the organ's going to 7 people, the only way to get this donor into the trial is for all 7 to agree to consent to it.
Yeah, I mean, obviously most don't donate 7 organs, but that is the tough reality.
Yeah, no, this is amazing. I mean, I think this is interesting. Okay, I was curious about the practical aspects of that.
Thanks, Anna.
This is divisible by 4.
Hi, Maureen. Thank you very much for presenting the study. It was very informative, very interesting. I'm wondering more about tacrolimus itself, the dosing, the timing, and the infusion. Why did you choose, for example, to give it intravenously as opposed to sublingually in the donor? And so you're giving it within 8 hours of organ donation. So is the mechanism of action believed to be through transcriptional regulation, or what's the dominant mechanism of action believed to be in this particular setting? Thank you.
Okay, thank you. So the reason we chose intravenous is because there's a number of reasons, actually, but first of all, these are, critically ill patients, mostly relatively stable, because they are going on for donation, but many of them are on vasopressors for sure at the time of, even up to the time of organ recovery. So the bioavailability and rapidity of uptake of sublingual or enteral formulation, we weren't sure of. I can't remember the investigations that we found about sublingual. And so that's why intravenous. And the timing was, I can't speak so much to the precise mechanism, and I don't know about that in the detail that you do, of course, but we did a lot of work with transplant pharmacists around the timing, so that we want it to happen definitely before organ recovery, but not too soon before, for logistical reasons and also for bioavailability. And so if we just thought administer over 4 hours for safety and to achieve the drug levels that we would like. And that's really all I can say to that.
And could I just add to that, I guess, will you have some kind of measurement at the level of the tissue? Are you planning any secondary analysis at the level of the tissue to determine whether, tacrolimus treatment had an effect?
That is a great question. Thank you. So yes and no. So we haven't planned any of those studies because we're in the donation world. And that would be, those would be great add-on studies from the transplant research community. And we would completely encourage as many studies like that people would be willing to undertake in this framework. And it would provide so much more information.
Thanks. Yeah, great idea. I think I can encourage people to reach out to you directly if they have ideas for add-on studies, right? So,
or to Marcus, yeah.
Yeah, or to Marcus, yeah. Dipali?
Yeah, hi, Maureen. This is a really interesting study. I just have some practical questions. So I guess first question is, who's doing the donor consent? Is it the on-site Trillium coordinators?
No, because we've learned from other donation research in Ontario over the past few years that is way too much for them to take on. They don't have, they won't all understand, the nuances of research and of this particular study. They don't have the time, they don't have the training to do. They understand the importance of training for consent, for donation. And it's just as important to have the appropriate training for consent for research.
Okay.
So we'll have our critical care research coordinators doing the consent.
Okay. And then my second question was with regards to the tacrolimus. Some of the donors, as you know, are at small hospitals and so on. So will you have IV tacrolimus readily available at all these hospitals?
So for the pilot study, it's only for the 4 hospitals, Hamilton, St. Mike's, Kingston, and Ottawa.
Okay.
And they do have it. And then as we roll out to a larger, the full scale trial, then that might, I do imagine that there will be community hospitals participating. So for instance, Trillium Health and William Osler participated in our observational study. And they would probably have it, but it would, be a requirement to participate in the study.
Okay, thank you.
Thank you. John?
Hi, Maureen. How are you?
Fine, thank you.
Great to see you.
Yes.
Excellent presentation. Congratulations. Just a question also around consent. It's clear in my mind, is the intention is to consent the recipients at the time of listing, which we do for many trials, or at the time of organ allocation? I can just imagine, it was already articulated, some of the logistical challenges in coordinating this. And I might also wonder if there's a perception that from IRBs or others that, at the time of when you're allocating organs, if you are asking somebody to consent to research, there may be some influence or sense that you're pressuring that individual to participate in that trial. And I know that's been a concern from IRBs in the past, that you're wheeling the patient down to the OR and asking them to participate in a trial. It perhaps is seen as being too much pressure and not allowing them time to consider and ask questions about the trial.
Yeah, so that's, I'm not sure about the specific question, but that's why we're doing the clinical consent to just receive an organ associated with this study at the time of allocation.
That's what I mean. So at the time of allocation, it's pretty close to the time of their transplant versus when you're listing the person, you say, well, we have this trial. Would you be willing to participate in this trial when, 6 months from now, an organ is offered? And they would have time to reflect and ask questions and consider. It's a lot easier because then you can just look and you got, oh, this person's consented, you have all your recipients lined up. It would be much easier, I think, to operationalize.
Yeah, I really appreciate that. Most people from the transplant programs we've presented to feel that this would be infeasible at that stage, like in the pre-transplant clinics. And I don't know if it's because there's so much else under discussion, or because the chances of, especially in the pilot study, of a patient actually being involved in the CINERGY study is so low. So there's all the reasons that I highlighted. But having said that, in Kingston, they're going to pre-consent everybody well before the time of organ allocation.
Yeah.
But the other programs just felt that this was going to be infeasible. So I think what's going to happen is we're going to find that it works well. We're going to get a lot of feedback from the recipients. We should, in fact, develop some mechanism for soliciting their perspectives down the road about how that allocation consent went. And if we find it's infeasible, then we're either going to have to take it to the transplant clinics, or because like most of us, I think all of us see this as a very low risk study. And if we find that it's just impracticable to get the recipient consent, then the research ethics boards would be open to hearing about a waiver of consent, or a waiver of consent for the clinical application.
Like be part of the feasibility component of the trial. Yeah, thank you. Right.
We'd have to first show that it's infeasible. That's the thing. Hopefully it's feasible.
Nikki?
Hi, thanks. This is really interesting. I'm a nurse practitioner in transplant, but I've also worked at the St. Mike's Trauma Neuro ICU as a nurse practitioner. So I love the intersection of both worlds. Mine is just more of a practical concern about, again, the root of the tacrolimus. We do see neurological complications like seizures with patients sometimes when we give IV calcineurin inhibitors. And I know that patient population who are donors are at high risk of having seizures and other complications. I'm just wondering if that's one of the anticipated potential consequences.
Well, for the donors, we're only enrolling neurologically deceased donors, so seizures can't happen. But if we roll this out to donation after circulatory death, which a lot of people are sort of suggesting we do, then that would be a consideration. But I'm not sure, Nikki, about the seizures, if that happens with a first dose that's going in over 4 hours, or if that's happened in, my understanding is that these sorts of things, even idiosyncratic responses or complications, are happening more in the context of people who are receiving recurrent doses intravenously and other anti-rejection medications as well.
Thanks. Yeah, it's a good question, Nikki. Laura?
Hi, Dr. Meade. Thanks for the talk. That was great. I just wanted to comment, just to follow up on John's comment that we do actually in lung all the time, the surgeons do the consent for transplants, and then we consent for lots of studies. And many people don't get enrolled, but we just sort of have a list of patients who are potentials for lots of different surgical intervention things, like, Marcelo's NPOD study and things like that. So we already sort of have that practice here of enrolling patients in different studies and creating a list and stuff. So just to kind of put that out there, that I would say for at least our lung program, we already kind of have that model developed. So,
well, so we might individualize this as we sort of have with Kingston, and that would be an incredible opportunity, I think, to learn how it works differently if we use these different models, and I think that approach would be much more feasible, or not necessarily feasible, much more successful. But I'm not sure. I think part of the early reticence from the transplant community might have been that, no, this is a donation group bringing donation research. We've got our own research that, we need to get consent for. But as, we really want this to be a joint effort, and for the transplant community to feel a part of it, and take advantage of the opportunity that it provides. And then it very well may be that opens opportunities for consenting in the transplant clinics.
Yeah, thanks, Laura. Jed has a comment. Jed, maybe you want to just iterate your comment rather than me reading it.
Yeah, sure. This was very enlightening. I think that to the extent that you're able to enroll enough patients, the CINERGY study itself may demonstrate that this kind of research is possible in Canada in a way that's consistent with principles of equipoise, consent, and privacy. My only suggestion was regarding communications. I do think there is a degree of unease out there, both among the public and within the medical community, around what may be done to organ donors pre-mortem, and the language of donor management and donor intervention potentially raises that issue when it isn't really what's central to this research at all. So my suggestion was if we could specify post mortem donor interventions, or even better, post NDD, I think that would put a lot of minds at ease.
I see. That's very helpful. Thank you, Jed.
Thanks, Jed. Yeah, it's a good point. I guess if we're rolling this out afterwards to DCD, then there'll be a different messaging. But
yeah, that would require a different analysis, I think. But there's no need to cause more alarm than is actually relevant in light of what you're contemplating.
You know, I'd like to just mention to folks that, in fact, we've done this qualitative research. A PhD student working with me, where she interviews transplant recipients about these issues of consent in donor management research. And one thing that we're hearing almost unanimously is that if the donor family wants this research, it is not for us to say that the research should not be done. Like, they want it to be done, that's their decision, that's not my decision. And then I can just decide whether or not to take the organ. So that's sort of reassuring to me. I don't think it's the best approach, actually, because there are also implications. If they declined an organ, then the next one offered to them would, you know, in the full-scale trial, probably be a CINERGY organ as well. So there are lots of corollaries that they might not have appreciated in this qualitative research. But just the fact that they feel like if the donor family wants it, then they want it, then I think that takes a bit of pressure off at the time of allocation.
That's really interesting. We're kind of operating in an interactive system, and the one contextual aspect that I would want to be mindful of is what is being communicated to the public. So if this starts moving to interventions after DCD, it's not really so much even necessarily what you're doing, although that's part of it, but also what people are being told about. I would not want, for example, OPOs to be putting out the message that you will be treated no differently if you are an organ donor, if in fact that isn't literally true. So we kind of have to make sure all the pieces are aligned.
Yeah, that's a very good point. It's one of the reasons why Fred really pushed back to just start in the NDD population.
Yeah, I can see you took a very thoughtful approach.
Mm-hmm.
Thanks, Jed. There's a question from Gary. Is the study powered for a specific outcome? How did you arrive at enrollment of 320? And then the second question is, are there any stopping rules?
It was powered around the rate of enrollment of, is it donors or recipients? Of both, actually. And I think the primary analysis for the sample size was around the rate of donor enrollment. And we judged that, you know, the study would be feasible if we achieved a certain rate, which was 70%, or I think it was the lower boundary would be a 70% rate of eligible donors being enrolled. we're anticipating much higher, but the lower confidence interval would be at 70. And then it would be judged to be feasible. It'll be different for the full-scale trial, obviously. And I'm sorry, I forgot the second part of the question.
The second question was whether you had any stopping rules.
Oh, we are convening a data safety monitoring board, and we don't have statistical stopping rules, but we are, collecting safety information around the time of the infusion of the drug, and specific data if there's any adverse events in transplant recipients that anybody judges might be related to the CINERGY study. And then all of that will be reviewed by the DSMB, and with the potential for them to recommend stopping.
Thank you. Any other questions, comments, suggestions for Maureen? Okay, if not, thank you, Maureen. You can see that there's a lot of interest generated, and with the amount of questions that you received, so I think people are pretty excited about this, and we wish you and your team the best of luck in this.
Well, thank you so much for the opportunity to present. And if any of you do have concerns about logistics or reasons why you would not want to have one of your recipients participate in this study, if you could, communicate that to Marcus or to me, then that will just help us to refine the procedures and the whole notion of the study.
Okay, thank you
very much.
Okay, bye-bye.
Bye now.
Bye, everyone.